content information in large and small groups so that you encapsulate the patient experience without unduly putting them in harm's way. So after you locate around a Post-it note, we have some questions for you to answer on it so we can give to Dr. Court as we prepare for the clear site visit. Parker, catch this. All right, so everybody would have to have a designated writer at their Post-it notes. One of the things that we need to ask in this session is how well do we do handover here? Initially when this was given, Dr. Hyde gave it, and it was for internal medicine, but we're expanding the here as a product of the patient environment at Erlanger Health System and the UT College of Medicine, Chattanooga. So the first thing that you'll have to write on the Post-it note is, do you do handover? Yes or no? And I know y'all are gifted individuals, but even doctors have to get up and write on the Post-it notes. So somebody's got to get up and write. Do you do handover? And then after we write these questions, each residency needs to report out. How many times a day do you do handover is the next question. You can feel free to elaborate, and you can put if it's different for a ward handover, if it's different for an intensive care handover, it's different for a same-day surgery handover. You can let us know as much as possible. But do you do handover, and how many times a day do you do handover? The question after that is, what systems do you use to make sure that you have an effective and efficient handover? Do you have a mnemonic or a written or spoken tool that aids in your ability to transition patients through phases of care? If you have a tool, please name it and ask it, and then we ask if you've been formally trained on it and you've had documented competence in it. The next question is, does everyone think that you have to have safe, effective, and efficient handovers to embrace a culture of patient safety regardless of geographic location, time of day, or any other boundaries that are placed in front of you, whether it be physical barriers, whether it be staffing, someone calls in? Must a handover always be done consistently every day, same way, same method, no matter what? And then the last question that we'll give Dr. Court some feedback on is, what barriers are in place at our institution in helping you or prohibiting you from doing a safe, effective, consistent, efficient patient safety handover? Because one of the things that we would have to do is assess what our current state is. Because if we allow a culture of ineffective and unsafe practices to continue without aiding you in your very hard and meticulous positions, that would be unfair to you. And personally, I want to thank all of you for your hard work and your dedication to patient care. I think it's a privilege to get to work with residents, and I really appreciate all your hard work, and I'm sure many of the faculty you interact with do. But publicly, you can put me on record as saying I really, really appreciate you guys a lot. So let's report out a little bit, and then we'll go through this presentation. Because at the heart of this is a mnemonic and a way to do things, but it's not the only way to do it. It's just something that we've done in a couple programs and have data on. So Laura's going to go first.
What would you like?
Read your answers for those questions.
Okay. For the family medicine team, first question, yes, the family medicine team does do handover. Second, it occurs twice a day on the inpatient service, once in the morning and once at night. 3, it's organized by the inpatient list. We don't have a particular IPASS or any sort of verbal structure, but we use our patient list that has the patient's history in order to adequately make sure we cover all pertinent points of that patient's care.
Is it a list that Epic creates or you guys create?
It is created by Epic and then augmented and appropriately adjusted by the residents on the service.
Okay.
4, yes, is the answer to that question. It's a very long question.
Yeah.
And
And
I didn't
then,
want to keep writing.
do you have anything that prohibits you as a system from doing effective, consistent patient handovers?
The one concern that we came across was that handover itself is not officially protected time, and so is prone to interruption. If we have a laboring patient who shows up down in an L&D or something like that happening, then obviously it would have to be interrupted in order to adequately address patient care.
So, and that could be a patient care interruption with an active person in labor. Do you ever get interruptions electronically or distractions?
Yes. Tiger text is ubiquitous.
From all levels?
Yes, we have a conference room that is designated for our handoff space.
When you guys do handover, do you have any signage or anything that says this is your protected handover space and that you're in handover, do not interrupt?
No.
Okay. Sean Zing, you want to go through what internal medicine does?
Yeah, we have handoffs.
Wait for the microphone, though. Wait for the microphone.
We have handoff about 2 to 3 times a day, depending on whether or not you're the call or the not call team. 3 times a day if you are the call team, basically. We have twice a day for an ICU. We primarily use IPASS or SBAR for our handoffs, and we do think they're important, and everyone does do them in a consistent time. And as was previously mentioned, we do get interrupted with pages, nursing, things like that.
Do you have a dedicated space free of interruption for handovers?
Yeah, we typically use our resident handover room, and then in the ICU, we just walk around and go through that.
What prompts people to use IPASS versus SBAR? And does everyone know what SBAR is? We're going to learn about IPASS, but SBAR is something that especially the Joint Commission, when it accredited this hospital, would want you to be fluent in. We have a different accrediting body now, and I'm going to give you a handout about that. But it gets into those situation, background, different things. So one of the things about all the healthcare accrediting organizations, and as we try to not only meet but exceed the standards for our accreditation or our clinical learning environment, is if we use something, you may be asked by a colleague, an attending, a nurse, you may even be asked by an environmental service what some of this word soup is, and you might want to put something on your physical body attached to it if it's not, to explain. Because if someone says, how do you hand over patients, and you say, I use IPASS, and then they ask a second question, what does the P stand for, and we have a blank expression or we pause and use ums, that's not going to make that survey visitor feel very reassured that that is ingrained in our culture. But more importantly, if that was your parent, that was your relative, close friend, and you came to the hospital and asked their physician how they transitioned from one to the other, you would want someone to feel like, I really think this person gets it. And they know how to hand over to where I don't have to be on pins and needles without sleep and be fatigued worrying about, is my family member going to suffer an adverse medical event because information is not getting from one team, from one person, from one shift to the next. All right, Parker, you going to do peds?
Sure.
All right. Wait for the microphone.
All right, in pediatrics, yes, we do hand over. How many times? 2, morning and night. And sometimes we'll do it with admissions, depending on an admit resident. We use a system base, IPASS as well. We try to include that. We also have a handover. We have a safe handover. We have a specific room that we use. We have a sign. And sometimes we get electronic interruptions from the ER for admissions, but that's been getting better. So.
Gotcha. Do you feel comfortable when you're interrupted gauging the interruption and telling those people that you can react to it after handover or assign a team member to go to if it's more emergent and needs to be taken care of right away?
Yes, we do.
Does everybody feel when they do handover that they can gauge the situation and remain in handover so that way effective patient care can still be delivered from the person asking you the question, but your transition can also be safe? That would be a question of culture, so we would want to say yes, and we would want to make sure that you're empowered to say, this is important time. Everybody has worked in this hospital to know the nurses have handover time, and they are pretty adamant that they need to do it that time in a way where they can safely transfer those patients, and that needs to be something that if that's a best practice, we need to incorporate too.
Only pushback we get to that is the PACU.
So if there's a patient in the OR and coming out, we've had times where they've paged us and we're saying, hey, we're in handover, give us 30 minutes to finish, and they say, no, the patient's coming over now, we want to hand over now.
So you get pushback from
PACU.
the physician or the nurse?
Both.
Both, okay. Will you write that on there for Dr. Court? In the back, the fellowships, what is your experience with handovers?
What was the first question? I wrote yes. I don't remember what it was.
Do you do them?
Yes.
How many times a day do you do them?
Cardiology twice a day. We do 12-hour shifts, and then GI hands off every 6 days.
We don't have a primary service.
Okay. So they do it 0.2 times a day. Yes, we do use a handoff tool. So do you guys. Fourth question was answer yes, and then we don't have any distractions.
Do you think that your distractions are limited because your level of training is higher, that you have a filter below you, or you've made people that work with you understand the value of handover?
So GI, probably limited distractions because it shows a great field to go into. Cardiology, we don't run codes, and our pages, we're going to work as a team, and if there's something emergent, then we'll do handoff. We'll prioritize, and someone will do one thing and someone the other.
So we all do handover. Sometimes we do it 2 or 3 times a day. What time of day do we do handover for internal medicine? 7 a.m. and 7 p.m. Yeah, and it's different at the end of the day for different things. Family medicine, what time do you do handover? 6 a.m. and 5 p.m. Peds, what time do you do handover?
6:15 a.m. and 5 p.m.
6:15 a.m. and 5 p.m. And then you guys in the back, 7 A, 7 P. Okay, so we're kind of a little different all over the place. So imagine working with nursing administration saying we want to protect resident and fellow handover time. And you guys have worked here sufficiently long enough to know that if you gave them 4 different times, do you think that we can come up with a way to protect time through Dr. Key's office as a CNO? We should be able to always say yes. Now, how we get to yes may mean that we need to look at ways to communicate with the nursing units that work with us, and then we need to inform them and increase the visibility and transparency of when you're doing it, where you're doing it, and why you're giving the answers you're giving. Because their staff may be a composite of people that are pulled in for a shift. They may be regular people on that ward, or they may be new to Erlanger. They may have, just done their orientation and still on their 90 days, whatever. So they might not know what the services of the patient, those kinds of things. So imagine the complexity of why Pam can't just send out an email saying residents are doing handover this time of day and this time of day, because you're all saying that you've identified times of the day which are specific for your patient care lines that you know best and that you know how to take care of. So we have to think where we're at and who we're working with. But at the end of the day, when the family asks you what went wrong, they're not going to probably be sympathetic to complex systems issues that put their family member in harm's way, right? They're going to want to know what went wrong, did we know it was going to go wrong, will it go wrong again? So if you look at Sentinel events, we all put in e-safes, we all have this kind of culture of patient safety. What is the number one root cause of Sentinel events for the Joint Commission? And that was communication. Now this is data that is a little dated now, but I promise you it's not different. What is the heart of medicine? Communication. You between a patient, you with each other. If I told you to go pick up my car and said that it's a blue BMW and it's parked on the 3rd floor, and you didn't know how to drive a stick shift and you walked over there to pick it up and I didn't tell you it was a stick shift, that's going to be a lot of energy and the endpoint's not going to be achieved. And imagine if your row is full and you read the first line of a novel, by the end of it, if you're really into it, you could probably keep up with all the verbiage and all the adjectives and everything, but as it goes from person to person, you're going to lose some of that. So communication is still going to be one of the things that always impedes the transfer of patients in a safe way. We do have a new accrediting system. It is not the new Joint Commission, as some like to say it is. It is a different accreditation. So I printed out this to kind of help people if you ever get asked why is DNV different from the Joint Commission, and it also has information about healthcare facilities accreditation programs. So if you want to take one just so you know and put it in your pocket, you can. Just take one back to that question. I took a health law certificate to the University of Louisville last year, the Brandeis Law School. And I can tell you the biggest difference between the Joint Commission and DNV is how it meets the mandates of CMS and the scope that it has. But both will ensure that we're having accreditation standards and assessment methods that meet patient safety, and as a part of that, effective and safe communication. So communication, but also look at the kind of physical environment plays a role in how we get the information to each other. Are we using an Excel spreadsheet that may or may not be updated? Does everyone know how to update it correctly? Was everyone trained in the same way? Are we using the EMR? And because we say we have Epic doesn't mean that we have the same Epic from site to site, service to service, or place to place. So we need to make sure that we have a quality assessment mechanism for, is what we're doing really worth the time we're putting in it, and is it meeting the goal that we're doing? The other thing is medication, special interventions, anesthesia. But I can tell you that the big focus on transitions of care in our clinical learning environment is always going to be your ability to communicate patient information amongst your team, intra-team and inter-team effectively. So this is something that came from this thought that we need to come up with a way, we being the pediatrics culture, to enhance performance and patient safety. You have to have some kind of basics. You have to support each other. You have to know what's going on around you. You can't be a fly on the wall, and you can't be totally aghast when something goes wrong. If you weren't involved and you didn't use your voice, your brain, the things that got you an MD or a DO degree or a PA or a soon-to-be graduated med school person from working. You have to have structure in how you talk. So you have to envision what kind of system can I use consistently, daily, and effectively. And then you have to have a leader. So knowing that, when you reframe handover from something boring something that is a checkbox, something that keeps you from going home and then you may run through a little bit quicker, then we have to know what we're doing. So the goal of the iPass creation was that we wanted to standardize it. We wanted to make sure that it improved the quality, but it didn't hinder your ability to do it quickly and effectively. Show of hands. Giving a presentation for handover is exactly the same as giving a presentation on rounds. Who thinks so? Show of hands. How many times have you sat in handover and imagined that is the same presentation that the patient got on rounds? There's at least 2, 3, 4. So that's going to help more than anything because your attention span is what it is. If you have distractions, if you have other things, a full presentation isn't the goal of handover, right? Handover should meet the technique of the tool that you are implementing. It should have some key things. You have to know who the patient is, a reasonable articulation of what they look like and their status and their physical location. Do not hand a patient over, especially on an adult service line that can encompass more than 2 physical buildings without giving a location, because you guys have been tiger texted by the nurse. 326, 7025, HCO3 can mean 18 million things, especially in the first 3-4 months of the year, right? So we have to think about, are we helping people that give ineffective handover with feedback saying, this isn't rounds, this is handover, we need to do this differently. Usually that's best done when you have a leader of handover. If you have a group handover by mutual decision, that is going to be the luck of the draw. If you have someone assigned to give and lead handover, so if it's a team, the senior resident, if it's something to where it's all on one peer level, you need to talk with your peers and say, which one of us is going to step up and help to guide this process? And we need to make sure that we do it in a way that we understand everything that's going on around us. With understanding the barriers and the flow of patients and what goes on in their world, we will understand a little bit better of what happens when we leave and come back. And we want to make things safe. So if you do handovers well, you want to make sure that you acknowledge those people that are doing it well. You want to take pride in them. You want to make sure that you coach up, and then you want to make sure that you feedback. You don't want to always do negative, articulate handover critiques. You're going to have to sit down and analyze it and take pride in that this is someone's life that you are talking about. This is something that could happen, and we don't know when chance will come into play. So we have to take it serious, and we have to take it as part of the job. It's not going to be discoverable in a litigation, but I guarantee you if you get on the stand or do a deposition, they're going to say, what was the communication technique used in handover with team, nursing, and other people involved? And you will want to say, we do it consistently, we do it in a patient-safe, centered way, and this is what we do. Because you don't want to be in a deposition for the first time thinking that we don't do handover in a safe way. You want to make sure that as we have come up with night medicine or night float rotations, that those people that are likely covering more patients from multiple teams and multiple care plans can do that safely and effectively. Because how many people think that night float is the same as days? It's not, right? What's the biggest difference about night float? Ashley, what's the biggest difference in family medicine at night, you think?
All by yourself.
You're by yourself. Do you have scheduled lectures?
No.
And then do your pages go up?
Yeah.
Yeah. Yes, what is the biggest thing about night float in medicine? Other than the 4 beepers that wear your pants down.
You're responsible for 40-some patients.
Mm-hmm.
Opposed to during the day, you just have your team's patients.
Right. So, I mean, the amount of people you're covering goes up, your technology use goes up, But that's 40 patients, and imagine that's 40 nurses, 40 respiratory therapists. Now, that's not meaning that the same nurse can't have multiple patients or the respiratory therapist, but that's the potential call or a point of contact for all those people. And if someone says, peace, here's a list, and leaves, and you're chasing your tail, are you going to have time to stay hydrated, make sure that you're not becoming fatigued, make sure you're not losing attention to detail? Well, what about PEDS and night float or night medicine, however you want to term it?
More patients, more admissions, slightly longer hours.
So more patients, more admissions, the time's longer, and then there's more volume in the ER coming through, you think? And so does that volume in the ER at night change the complexity of the patient compared to the day? Yeah. May not change the pathophysiology, but it just definitely changes what resources you have around. How many people, how many boots on the ground, what the nursing support is, and then can you get diagnostic ancillary services quickly, and what you have to do. What about as a fellow? What is your experience at night compared to the day? Yeah. So if it's higher stress at night and we're handing over to a higher stress environment, do we want to do it poorly? No. So we want to do it to where these people are stressed out. You don't want to stress them out even more unless you're a sadist, and then we got to talk about something else. That's a different lecture. But the ultimate goal is we want to take care of people. We are in medicine for patient care. We are also educators. We are also compassionate, empathetic people, but we have to make sure that we don't increase undue stress for each other. And they may never tell you that you're increasing their stress. That's something that comes with communication. But if you have bad handovers a couple of days in a row and you're on nights and you know that that is the reason, there needs to be a common ground that you can say that we need to talk about this isn't working. Now, you don't want to put blame necessarily on a person or an attribute if you can avoid that as a group without involving your attending or whatever supervising physician you have in that kind of chain of command. But you want to say, this is why it didn't work. The nurse for 346 called 18 times on stuff that should have been done prior to checkout. That caused me to get delayed on 3 ER admissions, and then I am behind, and it may affect someone's care, and it may come down to a vital medication mistake, and it may be a cascade. Your delay can delay someone else and can delay someone else through the care team, and the patient is staying longer and having to be in the hospital unnecessarily. So we have to communicate patient information and performance. But the goal is not to make handover war and peace. It should be a nice of mice and men experience, and you should set a limit. How long does handover take? You define it. You're the team. You're the pediatric expert, the internist, the family medicine physician, the cardiologist, the gastroenterologist, the general surgeon. You define how long it takes. I'll tell you from my experience, if it's over 30 minutes, you're stretching someone's ability to pay attention. Because you can turn your beeper off, you can turn your phone off, you can do those things, you can set a quiet zone, but when you come out of that quiet zone, you're going to light up. So how many people have set limit for handover? Does anybody say this is it, start a stopwatch and say we got to do it? It's hard to do as a doctor, right? You got to get through the list. You got to make sure all patients have equal weight and equal ability to articulate what is going on with them. But when you give a presentation or you sing a song, you're not going to sing it 3 minutes and 30 seconds one night and 5 minutes the other necessarily unless your audience changes or you're inebriated or some other factor. So we got to make sure that you're setting yourself up to succeed. Do you have a room? Are you showing up at the time that you guys set? Probably it's cute to be late every once in a while, but late every day is an issue. Not starting, not finishing, and not saying this is where to go, and please do not interrupt for unnecessary things. Because cute wears off. And then we have to think about what we're all doing together, monitoring situations, being aware of what's going on, And then we want one outcome, a safe patient. Yeah, if you put a kid on a bus and you don't know what to do, the kid is not at fault, right? It's who made the communication. You also want to make sure that if you notice something, you're all very intelligent, hard-working people that are observing. So if something is not right on the team or during the handover, watch each other's backs and make sure that if you notice something that is going on that can be improved, changed, or made different for the patient to have a safer experience, you should want to say, we need to look at this and we want to change it. Also, when you talk about workplace environments, there's a lot in industry that, you know, they have a debriefing. You may be at Walmart and they say, come up, all associates come up for the 9 a.m. morning staff debriefing. Home Depot does that. The airline industry does that, different things. They do it because it's proven to keep people on the same page and keeping the wheels turning. Why don't we do briefs and debriefs? Because we're busy and we typically have something in our mind that's keeping us from doing it. Now, sometimes emotion and different things get in the way of doing a debrief, but the challenge would be to avoid it altogether is never going to be the answer. So at the beginning, you should be on the same page. You should know what the goal is, who's doing what you have resource-wise, and what's going on. So that occurs at those times that you guys are giving handover. And if you have a need, you may have to suck it up, but most of the time not. You need to communicate something. So at the peds bed huddle at night, if something is wrong, the RT is not keeping up with the treatment, not letting someone know is not going to help the patient. It may increase your eSafe reporting rate, if nothing else. And then, do we ever say, do you understand the words coming out of my mouth? Do you get it? We do sometimes with patients, we round in the room and we have this philosophy about family-centered rounds, or we talk about different kind of acronyms that hospital medicine or different people use, and there's this thing about teach-back. And teach-back is where the patient has been presented with something and they tell you what's going on and back in their own words so you can ensure understanding. Do we do that as physicians talking to each other? Sometimes we do. I noticed it more as a medical educator. When people irritate you guys, you say, you're not paying attention. What did I say? Do you do it regularly? That's the question you have to ask yourself. Are you asking people, do you understand what I communicated? If you're talking in a lot of acronyms and you're talking in a lot of kind of implied understanding, that other person has every right to say, stop, I don't understand what you're saying. And you're going to have to do it in a way to where you eliminate all those things. So IPASS works best when you help each other out. You set the goals at the beginning of the shift. At the end of it, you debrief. When something goes on, you get the team together and you talk about it. If you're playing a sport and you're losing by 5 runs or something, are you just going to continue to do what you're doing, or are you going to say, let's have a timeout and let's talk about what strategy we're employing and should we continue it? And then you need to make sure that you have everybody verbalizing that they understand. There's a reason that the Delta steward or flight attendant says, you're sitting in an exit row and I need you to verbally accept responsibility. Because you got some AirPods in or different stuff and shaking your head, that ain't going to help when the raft inflates and you need to step up and do the door. They want to know that you have heard them and understood them. Now, it's a very cursory check, some airlines, but in the end, that's the goal of it. So when you look at what of our barriers, it's the culture we live in, how we talk to each other, the physical layout, and what we try to do. Are we putting a lot of stuff into hands that can handle it all, or we got too many hands or too few hands? And then we take our tools, and our outcome is to work as a team, and increase patient safety. So that's where the handover comes in. You got to hand off, and you got to do it in a way that you can continue the positive benefit for the patient. So when you go back to your next handoff, look around. Who is leading it? Does everybody at the table or the huddle or whatever know what their role is, when they should talk, what they should say? Do you have protected time and space? We identified that this institution protection is not guaranteed, so we need to work on that. The goal of standardizing it is that we reduce patient risk as a culture by the same system from team to team, physician to physician. And if it works for one, it may work for the other, and if it does, how do we acclimate it to a different pathophysiology, a different age group, a different setting? You have to make sure that what you say is up to date, accurate, and relevant. Extraneous details about family history, other things that go on are good for morning rounds, but they may not be good for a handover because you are just going to melt over and start to forget. And then you have to know the audience. You have to know, are they on your level? How much experience do they have? Do they just come out of med school as an intern? They've been doing this 3 or 4 years? What's their level of training? And then no matter what that level is, you got to come up with a way to talk to each other effectively and efficiently with the same goal. Can you do them over the phone? You could, but what do you lose over the phone? Body language. Body language is really important sometimes, especially for comprehension. And then you have to pace yourself. If I talk too fast, if I talk too slow. Ben Stein versus the auctioneer is going to be a different approach on how to understand. But you got to pace yourself, and you don't want to go on forever, but you don't want to show up and 2 minutes later be done and not have anyone understand what's going on. For an effective verbal handoff, you need to make sure that you have a composite abstract of what you've said in a written form. Does that mean print out the note for all 20 patients and you walk around with a binder when you get called? No. It means that you have an effective written handover tool that says who is the patient, an abstract, where they are, and then the components of IPASS. So the printout is a supplement to the verbal handoff, not the other way around. The verbal doesn't supplement the handout. It's kind of like read the manual. I just handed you a big stereo instruction book and said go read it, and I already knew just to hit the power button. That would be putting you in a position that's not going to be helpful. And when you come up with a contingency plan, you need to say, if this happens, then do this, and be specific and succinct. And it can be call the attending, call the fellow, call someone else. We get a lot of times audits that say, if their blood pressure is low, give them a medicine or start a drip. Well, I'm sorry, but if I get admitted and y'all do handovers, say just start a drip, I'm going to ask some questions when the nurse comes in with a drip. So, and then who is likely to give you problems? And then how do you go, if you have a problem, up the chain of command appropriately and do it. So IPASS is a way to do this. One of the things that everybody said in med school that they want you to get out of it, no matter if you were a peds clerkship, a medicine clerkship, family medicine, is they want you to know sick versus not sick. IPASS does too. It divides people into 3 things. So when you present, you're going to say this is a such and such patient that is stable, unstable, or a watcher. So watcher implies you have determined they have a degree of dynamic change available in them that requires you to go and physically look at them. So the nurses should be hypervigilant about watchers. You should be hypervigilant as watchers, if a patient is a watcher. And if you get a call, you should physically feel like you need to go there. Some services have said unstable patients don't need to be in certain places. So in pediatrics, if the patient is unstable, meaning their hemodynamic status is unstable, the support mechanisms or the resources aren't there, they don't need to be on the general pediatrics floor. Medicine, we've said that if we want a team of 16 to 20 patients, 2 ICU patients is going to suck up a lot of time, and the other 16 to 18 aren't going to have it. So those unstable patients would be better off in a closed unit, to where those assignments, both nursing and physician and respiratory and other things, are better suited. So as a culture, IPAS is saying, you define what the patient is, and you place them in the best part for success. Would you have a watcher ideally on 3,000 that has a nurse ratio of 6 to 1 if you expected something bad to happen? Probably not. So you're going to start out the first sentence saying, this is a patient, are they stable, watcher, and unstable? And it's a subjective call. The person giving you the handover makes that assessment, and you don't need to debate with them about it. You need to know they have taken care of the patient for this period of time and have accurately assessed this as this. If you want to change your assessment after you go and do a detailed examination, if you have time to review the record and everything, you can change that. But at the time of handover, you go with what they tell you. The next part of the acronym is patient summary. A summary statement is not the HPI. You want to talk about what got them there, what has went on, and the brief A and P. The last part of this, I've always thought, is the most important, the action list. If you give me something to do, I'm going to know I have to do it. And you're going to have to tell me do it, when to do it, and who is going to own it. That way, who has accountability when it comes done? If I didn't tell you to do it, that's on me. If you didn't do it, but I told you it needed to be done, this is the time frame it needed to be done, and this is something that you have to take ownership for from your team, then that's on you. Don't make assumptions. Action lists are concrete, objective statements that are being made that you can physically achieve. We are not asking you to be Socratic about this and talk about the meaning of life. It means make sure that this is done, this does happen, and you do it. Situational awareness and contingency planning. If you have an action item, you have to have a contingency plan. If that person that you hand it off to experiences a barrier, you want to tell them, this is what I expect will make you successful in achieving the outcome of getting this done. If you know that the nursing ratio is not ideal, if you know the MRI scanner is down, if you know the ER is packed up, it's winter, there's a lot of respiratory cases, you have to make them aware of what you've been noticing throughout the day. You don't want to walk into a butterfly field and get stung with hornets when someone could have told you to be a little bit more observant. And at the end, what do you do at the end of every patient? You make sure that they understood it. That usually will have to mean that you ask the question, was that patient handover understandable? Do you know what to do? What questions do you have? And then as a second order, make them say what you told them. That way, them saying it back let you know how well they were able to not only listen but comprehend. Because there's a lot going on. There's little booms, bings, bangs, stuff. Everyone has a life. You think about your, your car, your kids, your significant others. All that still goes on in your brain, so you have to make sure that you're taking it back. So the heart of this mnemonic is you label the patient, you be concise, you say this is what you're going to do, this is what's going on around them, every action needs a contingency plan, and then every patient needs to be understood by the receiver. And remember that stable, watcher, unstable is a gut feeling, it's a subjective call. When you talk about patient summary, you're saying why they're there, hospital course. It should be concise. It should focus on active issues. If something happened 2 weeks ago or 2 days ago and is not actively going to be something that can put that next 12-hour period in jeopardy, don't bring that up unless it's inherent in taking care of that patient. Because we spend a lot of time, I know, on the services that I cover talking about, this patient's on a CON, this, and this. And then, at night, that may be helpful, but if they're going to go to bed and I don't have to worry about it, we probably could have used that 3 minutes for something else. You can do it based on what works best with you. If internal medicine, family medicine want it to be more elaborate because they have older patients that have more complex more systems involved, and they have more chaos in their system because they have to be, Ashley has to run to do a delivery and still cover floor patients and everything else, and Yaz has 40 patients that he's doing, then that's up to the service. But it doesn't have to be rigid by any stretch of the imagination. And remember, if you have an action, that's something's getting done, and you need to say when it needs to get done, who's going to do it. And then if there is nothing to do for the patient, make the bold statement. I have nothing for you to do on this patient. That allows that person to say, I'm not going to go look for work to do. And then if you get a call about a nothing to do patient, that may trigger your mind to say, this was supposed to be a stable nothing to do patient. I probably should, not dismiss a concern that's coming in. Because if the day team or the other team has everything teed up for success, you shouldn't be called. Right? You should just have that patient's care plan go through. So you got to know what's going on around you, who's on your team, what the physical environment is, and then at the patient level, what role you are, where they're at in their disease process, and then how they're progressing. So that means that you have to identify concerns, be vocal as what might go wrong. If it's in your brain, tell someone that I didn't understand or I didn't get that from you. Is typical of handover debriefs. But if you go ahead and articulate what you think could go wrong every time, then that's less likely to happen. If something comes up, if you have a resource that can help someone, go ahead and identify that. Say, call this, do this. Identify your resources. They're going to be specific to probably nursing units, patient care units, teams, whatever. For stable patients, you can say, I don't anticipate anything will go wrong. Because that's a statement that came from that person that said, I took a lot of time taking care of this patient. I don't think anything's going to go wrong. That should allow you to say, okay, I get it. And then you have to re-clarify the information that you got. So that also gives a person to say, I sit here and listen to you, but I don't understand a word you just said. Now, you don't want to get to the point where that is something that's repeated, because that's probably a technique issue or a culture issue that needs to be evaluated. But it gives them a chance. If they have a question, they can clarify it. They may know of a resource you don't know. They may know other elements that could come into play, and they want to go ahead and clarify that. It's a team sport. Everyone needs to be involved. And then it's hard to do. We talk about it. People that do educational research and do this a lot publish on it in different stuff, but when the rubber meets the road, it's hard to conceptualize and do. And then after residency, ask how many people do this the same way and see what your own real-world experience is. Know who's on your team, know what they're going to do, know that you have a place to do them. It's quiet, no one's interrupting you, and we work as a system on how to do that. And then when do we brief and debrief? And then you have to do this repetition. So probably the first thing you can identify is the space, the protected time, the quiet, the ambient ability, and then how each team's going to do. Dr. Court wanted to use the rest of this session as a breakout session. We have some IPASS instructors, Dr. Hines and Dr. Nelson, and then Ashley is going to be our designated instructor for family medicine, to break out into resident groups and ask yourself, if you're using IPASS, what goes well with it, and then kind of pick someone else's brain about how to implement it and what could help. We printed out cards and laminated for everybody's badge on medicine. You can also say, do the nurses know where my handover room is? Do they know what time to do it? If that's not commonly known, that's something you can take out of this meeting and talk to a service line member on how to help make that better. But go ahead and spend the rest of this time, which is only about 5-6 minutes, talking about things you can do. And if you need the GME office or Erlanger to step up, write it on one of these Post-it notes so we can look at it at a meeting with quality and safety, and we can put some skin in the game from our end. But does anybody have any questions? Go team. Are you British? What are you doing? Appreciate it.
Sorry.
I think
Every morning there's I'll show up.
Hello.
How's it going?
Good.
Nice to see you.
My name's Mike Carr.
Yeah.
I'm a pediatric surgeon.
Uh-huh.
I'm going to be moving into the role of directing the simulation lab.
Oh, nice. Okay.
Do you have an extra copy of that iPass good phone card? Give this held up.
Larry,
Up in the office.
I gave them to Dr. Court, but he should have some.
So
His office.
over in the UT office.
Yeah. He should have them that way. And then we made them big one year, but this year we made them no
hide
more
behind
bigger
the
than
ID.
that. Yeah,
Right.
so that way they can still identify. But it's worked pretty well so far.
Yeah. Department of Surgery, they had a paper a few years ago that they had published on their handoff tool, and I don't remember what it is. I don't think it's iPass.
No, I think it's something different.
I think it's one they created.
Yeah. Yeah, and they had a better situational awareness of what they wanted to get out of it. But I didn't see any. Dr. Court didn't have any surgeons that were able to give him any information. I don't think any were able to show up as to know what they're doing. But
Okay. Well, I know they've got their own tool.
yeah.
All right, we'll see how close it approximates
Sounds good.
iPass. All right,
Thank
thank
you, sir.
you.
I think our handoffs are pretty good. I think a lot of our level does a good job of saying, if this happens overnight, I always try to ask them how long it might take to think about what's going on. So I can pass them on to the night shot is, what do I do now? So I think you do a good job of thinking of opportunities, and then it tends to be a lot more of, okay, hey, this is a typical with bronchiolitis and brain illness, and then move on to they're on high flow, they get worse, they get gas, recheck, or shoot a chest x-ray. Like, I think we kind of built that in. So I think less than it was. So there always has to be the senior, always has to have the senior vet team